Hello students. Welcome to chapter 17, part 5. We are talking about HIV, and this is the second part of the HIV condition, okay? Now we are going to get deep into the assessment part of HIV. So we recommend that every person between the ages of 13 and 64 be tested for HIV at least once between 13 and 64, and more times if they are at high risk for contracting the virus. So if they have been exposed, or they believe, or there is any risk for contracting the virus more than once between 13 and 64. In the outpatient setting, the adult who is in a stage 2 or a stage 3 is monitored regularly for changes in immunity. That means the viral load or health status that indicate disease progression and the need for intervention. Remember that in stage 3, the CD4 T cells is going to be less than 200, right? Monitoring to assess drug therapy effects and for new or changing health conditions varies from every 2 to 6 months based on disease progression and responses to treatment. So that's important. In the part of the history, it is important to ask all patients about risk factors such as engaging in unprotected sex, needle sharing, or receiving a historical blood transfusion that may have exposed them to the viruses, right? Ask about the history or presence of any STI, sexual transmitted infection, and infection diseases such as tuberculosis and hepatitis, right? If the patient has hemophilia, ask about treatment with clotting factors. Okay, and then in terms of physical assessment, signs and symptoms, be certain to assess for the presence of any flu-like symptoms. Remember, those are very similar, and especially in stage 1. That could indicate infection with the HIV virus, such as swollen lymph nodes, sore throat, and fever. Stage 1 is characterized by those symptoms. The patient in stage 1 or stage 2 may be asymptomatic or have only minor symptoms. Also good to remember that. Always assess patients for opportunistic infections, even if they are feeling well, as organ systems changes can occur as immunity continues to decrease. Assess for clusters of assessment findings associated with the condition that may be present in the stage 3. Right, the most common opportunistic infections that occurs in stage 3 include candidiasis, cryptococcosis, cytomegalovirus, M. avium complex, Girovici pneumonia, especially the Girovici pneumonia, toxoplasmosis, and tuberculosis. And remember, toxoplasmosis is a condition acquired from cat feces, the parasites, right? Box 17, best practice for patient safety and quality care, taking a comprehensive sexual history. That's specifically that you need to ask to the patient whenever you're taking the patient history, right? In terms of the partners, are you sexually active, right? In the past 6 months, are your sexually partners men, women? Do you know if your partner currently have any other sexual partners? All this story related to the partners. And in terms of practices, you need to ask, do you meet partners through online venues or apps? You need to assess the environment, how they got together. Also, protection from sexually transmitted infections. Do you consistently use latex condoms? For women, did you use a condom during your most recent sexual encounter? And also assess past history of STI. Have you ever been diagnosed with a sexual transmitted infection? Do you have any history of STI? Have any of your current or former sexual partners being diagnosed with or treated with a STI. Pregnancy intention. Have you thought about having children? Are you currently using contraception? All this information is very important. Now let's move to conditions found in stage 3. Again, stage 1, the symptoms are similar to flu, right? Stage 2, depending on the viral load, but stage 3, you must remember that the CD4 T cell count is less than 200. Okay, also remember, from the moment that the patient that is not infected had contact with an infected patient, right? There is a period in which the viral load is going to be present in your blood. So probably the first time the patient is going to be tested, post exposure, the symptoms, the viral load is not going to be present in the blood work, right? So that's why the patient needs to repeat the test, okay, in a few months, on depending on how the doctor recommends the testing to be done. Now, conditions found in stage 3, infection with assessment findings and nursing interventions, very important table. So in terms of cardiovascular, we have coronary artery disease, right? Is this going to be present? And the patient is going to have chest pain, shortness of breath, so you need to apply oxygen if shortness of breath is noticed. In terms of heart failure, you need to maintain cardiac monitoring, intervene if these arrhythmias are noted. In metabolic abnormalities, for example, hyperlipidemia, hyperglycemia, monitor laboratory studies, the lipid profile, fasting glucose. In terms of endocrine, okay, also it's important to monitor the adrenal insufficiency due to opportunistic infections, right? Teach how to conserve energy, that's very important. And then hormonal changes, blood work is going to show you low testosterone levels, menstrual irregularity. So provide a safe environment for patients to express concerns. Presence of lipodystrophy, fat redistribution. This condition is less common with newer medications. You have to teach the patient about the fat redistribution. It's not uncommon. Recommend discussing possibility of treatment with desamorelin with primary healthcare provider. And then also dietary teaching, right, to reduce sugar and fried food intake. This is already, we review cardiovascular, endocrine. We are going to review right now the gastrointestinal. It's important to assess for anorexia, malabsorption, weight loss, okay. Encourage intake of high protein supplements. Also assess for intestinal infection. Monitor the electrolytes. Remember, anything related to the intestine, it has to be related also to electrolytes. So you're going to see that in your CMP, right? Your calcium, magnesium, sodium, potassium, blah blah blah. Wasting syndrome with unplanned weight loss. Encourage intake of high protein supplement drinks. If the patient is having fever, administer antipyretic. If the patient is having diarrhea, can result in AIDS wasting syndrome. So you always check your electrolytes, especially with diarrhea. Oral and esophageal lesion, right? You need to inspect, assess the oral cavity, administer antifungal medication as ordered. In terms of salmonella, septicemia, administer antibiotics. Now, if you're going to assess for the immune system, right, you're going to check for any bacterial, fungal, protozoal, or viral infections. And you're going to ask history of Candida albicans. You're going to assist with food choices that are soft and easy to swallow. Monitor for aspiration. And this is good to know. know, okay? Because candida is going to express in the mouth, so make sure you check the oral cavity and you teach the patient to eat a soft and easy to swallow food. That's good to know. Please remember this one, okay? In terms of cryptococcosis, you're going to institute and maintain safety precautions and administer pain medication for headache as ordered. In terms of nausea and vomiting, also you're going to monitor electrolytes. And also, let's move to, okay, that's good to know for Candida albicans, right? Okay, don't forget about that one. And then in terms of herpes simplex, this is another type of virus, or varicella zoster, mouth and lip sores. Check for that. Skin or systemic involvement with varicella zoster virus. So you're going to encourage patients without symptoms of HIV to talk with their primary healthcare provider about the shingles vaccination. Okay, so yes, all is patient education, but also you need to mention different types of precautions to the patients, right? To learn how to take care of their health, especially if we have patients that are in stage 3 with the CD4 T cell count less than 200, okay? That's very important. Also, patients that are having histoplasmosis, is infection begins with respiratory infection, right? So also, there is another table here, conditions that might be present in stage 3, toxoplasmosis, cancerous process with HIV, human papillomavirus, in terms of integumentary Kaposi sarcoma. So you have to recognize that this cancer is an AIDS-related malignancy that appears on the skin, rashes, neurologic, asymptomatic neurocognitive impairment, mild neurocognitive disorder, HIV associated dementia. Is wow, the list goes on and on and on. This condition, this disease is affecting, is systemic, is terrible. Sensory changes, gait changes, and reduced sensory perception, neuropathies in terms of renal. Remember that patients that die from HIV, they have problems with the kidneys and in the cardiovascular, and so it's a rapid deterioration in kidney function. Remember, your creatinine is your marker that you have to monitor, and your proteinuria. Respiratory, chronic obstructive pulmonary disease, Mycobacterium avium complex, common cause of non-tuberculosis mycobacteria, and conditions that may be present in stage 3. The list continues. Pneumocystatic gyrovector pneumonia. This is very common. Okay, so you need to apply oxygen as delivered. Okay, and that's good to know in terms of pneumocystitis. Gyrovector pneumonia. Okay, apply oxygen. Well, in all types of pneumonia, right, is very important. The presentation is going to be also with low-grade fever, and you have to administer antimicrobial and antipyretic medication as ordered. Basically, you have to support the symptoms and treat them, right? Also, the patient is going to have tuberculosis if they are having a stage 3 AIDS, right? So cough, dyspnea, chest pain, fever, chills, night sweats, weight loss. So we have to recognize, that's good to know in terms of pneumocystis, gyrovation, pneumonia. These are nursing interventions, okay? We are not talking about drugs yet related to these conditions, and we're going to focus on the most important only. In terms of tuberculosis, we have to recognize that a rapid molecular assay test instead of a sputum smear is the evidence-based methods of initial detection. So institute and maintain airborne precautions, airborne precautions for tuberculosis, and administer antitubercular medication as ordered. Well, it's very important, all of this to monitor. So basically, this was the list that we have to focus on when we are depending on the stage, right? But the list is more related to stage 3. So you have the older adults living with HIV. This is another good reading for you. With better treatment for HIV infection than at any time in the past, people living with HIV in stage 2 may live long lives. As I told you, there are people that if they have early diagnosis and they follow their treatment, and sometimes the viral load does not change and they are asymptomatic, right? Important is the psychosocial assessment to ask patients if they are engaging in activities that they enjoy and observe for signs of depression, anxiety, or suicidal ideation, especially in HIV, that right now is treatable. People are living with this condition, right? Before people had the idea that the condition was fatal, right? So, but it's all about assessing how the patient feels. There is another box here about important information. Maintain airborne precautions along with standard precautions for patients in stage 3 who exhibit symptoms of tuberculosis. We spoke about that. A rapid molecular assay test should be done to confirm the presence or absence of TB. Now, safety priority: assess patients frequently for changes in level of consciousness, vital signs, pupil size, or reactivity. That's all related to neuro. Remember that this disease affects all systems. It's systemic, right? So we have to check the mental status, also the limb, the strength. If any of these are present, respond by reporting them immediately to the healthcare provider. So laboratory assessment, okay. So we did the physical assessment, the psychological assessment, right? Now let's move to laboratory. HIV serologic and virologic tests detect the infection. Prior to any testing, it's important to let patients know that there is a 3-week zero conversion window. 3 weeks zero conversion window following HIV exposure, in which a test may produce a false negative result. It's 3 weeks between the day you had the exposure to the virus until the viral load is going to be seen in the blood result. Patients who have been or may have been initially exposed to HIV within the past month should have another test done following the seroconversion window if the first test result is negative. So there is always 2 tests, I would say, to be done after exposure. Testing can be accomplished by performing an initial chemiluminescent immunoassay test followed by confirmation tests such as the Western blot, which is that's the most important test for HIV, right? The Western blot, or by a point of service rapid HIV antibody immunoassay screening test that produces results in under 1 hour. And I've seen those tests done in the hospital most commonly. Another option for testing is to use an HIV antigen antibody combination assay. This product can detect the HIV infection 5 to 7 days earlier than a test that detects only antibody. So this test is going to check for antigen antibody combination. Okay, another one is home kits, which require a finger stick blood sample, are available for purchase without a prescription. The sample is mailed to a licensed laboratory and results are available within a week of shipment. The patient can anonymously register and receive pre-test counseling and results counseling by phone. This is sometimes the preferred method um, for some patients. Other tests for HIV include the oral mucosal transudate test and urine testing for HIV. The oral mucosal transudate test requires the patient to run a swab over the gums and gum line to collect the sample. So you see, we have multiple tests: urine, we have blood tests, you have your rapid test, you have the swabs. And now let's talk about the lymphocyte counts. Okay, so they are performed as part of your complete blood count with differential. It has to be CBC with differential. The normal white blood cell count is between 5,000 and 10,000. That's your normal WBCs, right? With a differential of about 20 to 40% lymphocytes as an absolute number of 1,000 to 4,000. Patients in stage 3 often have leukopenia with a WBC count of less than 4,000, and lymphopenia with less than 1,500, right, lymphocytes. And remember, your nurse love to monitor your neutrophils, your lymphocytes, and then your monocytes. So it's the second in the list, right? Your nurse love, your lymphocytes are going to be reduced. Okay, so then you have the cell surface immunophenotyping. So CD4 and T cells and CD8 and T cell counts and percentages are part of an immunity profile. So we have two types of T cells. We have the CD4 and CD8, right? Adults with HIV disease, especially in stage 3, usually have a lower than normal CD4 T cells and a normal number of CD8 T. Okay, so usually patients, again, with HIV, they have lower number in CD4 and normal number in CD8. Okay, so a normal CD4 count is 600 to 1500. That's normal CD4. And when the CD4 count is below 200, patients are at high risk for developing the opportunistic infection. And as we've been repeating, below 200 is stage 3. The normal ratio of CD4 to CD8 is greater than 1. The normal ratio is greater than 1. In HIV disease, because of the low number of CD4 T cells, this ratio is low. Low CD4 T cell counts and low ratio are associated with more disease symptoms. So we are mentioning this because it's important when you are going to review the records, the health records of the patient. You're going to see a lot of blood tests done, and they are going to focus on CD4 and CD8, and you need to know you're not going to be tested on this. Well, probably I'm going to test you about on stage 3. You need less than 200, right, CD4 T cells, but you need to be familiarized with these concepts whenever you read the blood work results. Viral load testing. So we spoke about the lymphocytes, the cell surface immunophenotyping. Right now we are talking about the viral load, also called HIV RNA quantification testing, right? Directly measures the actual amount of HIV viral RNA particles present in 1 milliliter of blood. So this result is used to measure prognosis. It's so important. Disease progression, effectiveness of therapy, and need for prophylactic therapy, and to determine survivability. An infected adult has no viral load for HIV. Again, an uninfected adult So a patient that is healthy, that is not having HIV, has no viral load of HIV, and the laboratory result will show undetected. Okay, the viral load usually parallels the course of disease. The higher the viral load, which can exceed 30,000 copies, okay, 30,000 copies, the more likely patients are to develop or progress to a stage 3. So close to a stage 3, the viral load is going to be close to 30,000 copies and less than 200 CD4 T cells, okay? And I want you to remember that. And the less likely they are to survive without a decrease in viral load. Less likely they are to survive without a decrease. So that's when medications are going to participate, not to stop the viral load, but to slow the progression of the disease. That's something that you need to have clear in your mind. To test for the baseline viral load should be conducted 2 to 4 weeks. Two tests for the baseline viral load should be conducted 2 to 4 weeks apart following exposure to HIV infection. Ongoing monitoring every 3 to 4 months may be recommended. So if retroviral, so the most important is that with HIV you need to continue testing based on your results, right? The doctor will recommend you when to come back. It's all about testing, and it's all about taking your medications, and the results of the viral load is very important. It's going to determine the disease progression and how they are going to treat it. If antiretroviral therapy is initiated or changed, testing is done every 4 to 6 weeks to determine efficacy. Yes, they need to double check on that. Other laboratory assessment to monitor the patient's health and detect any infection or problem related to HIV, blood chemistries, urine analysis, CBC with differential, toxoplasmosis antibody titer, right? Remember, is one of the opportunistic infections, so they are going to check these. Liver function test for STI, test for hepatitis, lipid profile, quantiferon, TB, and PPD, and cervical and anal Papa Nicolau testing. So other tests may be performed to monitor toxicities from antiretroviral drugs. So then in terms of genetics and genomics, HIV drug resistant testing is used to determine key HIV genotypic mutation that could cause resistance to combination antiretroviral therapy. So this is a new term that we are introducing in this chapter, is the combination antiretroviral therapy, meaning that that specific drug is going to put together drugs that are treating the 7 stages that we spoke in the first video related to HIV, the multiplication, the replication of the virus has 7 stages, right? From the moment the virus enter our human cells and take part of our DNA in order to replicate. So there are 7 stages. So the medications are designated to work on each stage, right? So this combination antiretroviral therapy probably is going to take medications, a combination of medication for stage 1 mixed with stage 4 or stage 7. I'm just trying to put an example, okay? So remember, this combination antiretroviral therapy is known as CART, okay? Patients who are candidates to undergo treatment with abacavir by itself or in a combination drug form must be screened with the HLA-B5701 test before the drug is prescribed. This is a genetic test that determines if a patient is a high risk to have a hypersensitivity reaction to abacavir. So before taking that medication abacavir, the patient needs to take the HLA-B 5701 to see if there is an hypersensitivity reaction, right? Which can range from mild symptoms to fatal anaphylaxis. And that is good to know. Is NCLEX alert in terms of this medication that you need to really pay attention to this medication, and especially to that particular test. Okay. Other diagnostic assessment is going to be biopsies, X-ray, ultrasound, CT scan, nuclear medicine scans, pulmonary function test, arterial blood gas analysis, and stool test, among others. Okay, so this is good to know. NCLEX alert. When we have the risk for anaphylaxis, this is a life-threatening situation, so it's going to be in NCLEX. Remember, anything related to safety and patient education will come on NCLEX, and you need to focus on that, okay? Try to be selective on the topics you are going to review for your NCLEX examination. Try to create a notebook with all these NCLEX alert. Okay, so the hypothesis is the potential to transmit infections due to lack of health education and risky behaviors, right? And the potential for infection and life-threatening complications due to reduced immunity associated with HIV infection. So what are we going to do for that? There are different steps that we have to take into consideration. So the patient in any stage of HIV disease, right? Where is this? Okay. Is susceptible to infection, regardless if it's stage 1 or 3. It's in any stage is susceptible to infection. Initial management focus, because remember also the patient also probably has another comorbidities that put the body in high inflammation state. So that's why the risk is there. Initial management focuses on supporting the patient's immunity by controlling the HIV infection with antiretroviral therapy, right? Reducing the viral load and preventing infection from occurring. So as the patient immunity continues to decline, management includes monitoring for and quickly treating opportunistic infections and other life-threatening health conditions that may arise. That's important. So we have to teach the patient to avoid exposure to infections, agents, right? And we are going to see a list in a few minutes for preventions to infection. We have patients in stage 3 may experience multiple infections. Some are co-occurring, and there is another table we're going to see with this information. Identifying an infection early reduces the risk for development of sepsis, and that's good to know. Also, NCLEX alert, we have to prevent sepsis, right? Especially if the patient is having low lymphocytes and leukopenia, right? Low WBCs. Patients with leukopenia may not exhibit tradition signs and symptoms. Plan to intervene even if something as simple as a low-grade fever is detected. Yeah, with patient with HIV, we have to really exaggerate our care with them, right? We have to prevent. Drug therapy, treatment with multiple drugs from different classes are used together in combination known as combination retroviral therapy. I spoke about this before. CART, combination antiretroviral therapy, CART. This approach helps to reduce the viral load, improve CD4 T cell counts, and slow the disease progression. Notice that we didn't say heal the condition. There's no cure for HIV, right? So patient and family education, prevention of infection, In general terms, you know, wash your hands, avoid crowds, do not dig in the garden or dirt, and do not maintain house plants. Very important, you see. As simple as that. Take your medication exactly as prescribed. Avoid travel to areas with poor sanitation, right? Report any of these indication of infection, temperature, persistent cough, pus or foul smelling drainage for any open wound, mouth ulcer, urine that is cloudy or foul smelling. In terms of personal hygiene, never share personal articles, bathe daily, brush or floss your teeth, clean your toothbrush. In terms of nutrition, do not consume undercooked meat, fish, or eggs. Pets, do not change pet litter boxes. Remember the toxoplasmosis that is coming from the cat feces. Okay, there are parasites there. And do not feed pets raw or with undercooked meat. So then there is another box, very interesting, best practice for patient safety and quality care of the patient with reduced immunity who is hospitalized. The care is different. So in terms of the room, place the patient in a private room whenever possible. Limit the number of personnel entering the patient's room, especially if they are CNA, that they are not having a special uniforms that they must wear when they are going from one room to another, right? Equipment and supplies. Keep frequently use equipment in the room for the use of this patient only. Blood pressure cuff, stethoscope, thermometer. Keep a dedicated box of disposable gloves in each patient rooms. And well, this is in general for all the patients, right? Standard precautions. Provide single-use food utensils when possible. Assessment and care. Monitor vital sign. Inspect the mouth, skin. These are nursing interventions. Everything is related to assessment and patient education, right? Obtain specimens of all suspicious area for culture, right? Give me 2 seconds. Okay, and use a strict aseptic technique for all invasive procedures. So very important. Missing or skipping doses of CART, the combination antiretroviral therapy, can lead to drug resistance because there is not enough of the drugs in the body to inhibit viral replication. That's good to know. It's coming on the exam. Okay, so missing or skipping doses of CART can lead to drug resistance because there is not enough of the drugs in the body to inhibit viral replication. So once a patient has HIV with resistant mutations, the resistant virus is stored in the body indefinitely, and the drug to which the virus is resistant can no longer be used effectively. Okay, so pay attention to that. Regularly stay informed about new drugs that are approved. Yes, because of the treatment for HIV has changed dramatically. Multiple medication has been added. In late 2022, lenacapavir was approved for treatment of HIV in heavily treatment experienced patients with multi-drug resistance who were unsuccessful on current antiretroviral therapy. Remember, so before it was thought that HIV was fatal, they start introducing different type of medication. Then many patients became resistant to certain drugs, or multiple drugs have been developed little by little to work and to prevent this resistance. So we have common examples of drug therapy to treat HIV. You have, for example, you see nucleoside reverse transcriptase inhibitor, okay, is gonna work on that particular part of the replication of the HIV. So when the virus enters and is trying to obtain information from the nucleus of the human cell, right? These medications is gonna work to reverse transcriptase inhibitors, right? It's gonna inhibit the transcription. So you have block reverse transcriptase to HIV cannot make copies of itself. Okay, so you have the abacavir, the medication that we told you before. The patient needs to do a specific test to see if the patient is not going to have any fatal hypersensitivity. Remember abacavir, also tenofovir, right? And we remember in terms of tenofovir, we need to monitor renal function tests and bone mineral density in patients taking this medication. Renal toxicity and decreased bone mineral density can occur. And there is another here, non-nucleoside reverse transcriptase inhibitors is another part of the replication, right? You have multiple medications here. Okay, basically liver, the kidneys, medications that are taking anticonvulsives, medications also could be contraindicated when you pair them with these HIV medications. Then you have the monoclonal antibody, the ivaluzumab, monitored during and after infusion. Hypersensitivity reactions can occur, and this is one of the most common side effects, the hypersensitivity, because we are really attacking the immune system. We are working on the immune system, right? Very, very it's a very persistent work in the immune system, not only by the virus but also by the medications, right? So we are working on that sector. You have the entry inhibitors, you have also the integrase inhibitors, so you have to monitor liver, kidneys. You have also the pharmacokinetic enhancers, boost effectiveness of other drugs. So in terms of the exam, I already told you in the blueprint what I'm going to ask you for, right? So some of the drugs noted below are available only as part of a combination drug. Reference and evidence-based drug resource prior to administration for a specific information on each combination drug. So then the card drug classes and actions are listed in a particular table. One of the key concerns associated with the card, which is the combination antiretroviral therapy, is the expense, right? The daily regimen is lifelong and can be financially burdensome. If needed, refer patients to the social work or case management, especially who can assist with finding ways to pay for the treatment. Yeah, it's very sad that some patients, they don't have access to this because the drugs are very expensive. Patient must take CART, this combination antiretroviral therapy, as prescribed to maintain the highest benefit. Today's CART drugs have longer half-lives than other medications, so efficacy is not lost as quickly if they are if they have a few misses dose. So the half-life is longer than before. Okay, so one more nursing safety priority: teach patient the importance of taking the combination card drugs as prescribed to maintain the highest medication benefits. It is important that patients attempt to avoid missing or delaying doses and to resume and continue their prescribed therapy as soon as they discover a missed dose. Ongoing missed doses can promote drug resistance. Okay, so that's good to know. So you have to take, if you miss a dose, you have to teach the patient to take that dose whenever they remember, and then continue with the following doses. It's not that they are going to take two medications, two pills at once to compensate for the missed dose. Okay. And there is a complication in some patients who have started this combination, this CAR therapy, is the development of immune reconstitution inflammatory syndrome, IRIS, immune reconstitution inflammatory syndrome, as their CD4 cell count rise and the drugs suppress HIV replication. That's why the CD4 count rise, right? T4 cells identify opportunistic infections that were present before but not recognized because of the severely reduced immunity, right? So the T cells begin to hyperact in the presence of these infections, which start an inflammatory reaction marked by fever, night sweats, fatigue, or new or worsening disease. In other words, while the patient was having low CD4, right, these soldiers, that are the soldiers attacking infections, the count was low, so they were not able to fight all the infections that were present in the body. So these infections were unnoticed. Once they start taking the CART, the combination antiretroviral therapy, now the CD4 counts increases. And now, since they are more, right, the military, the soldiers is bigger, now they start attacking all these infections that were unnoticed, right? And that is called the immune reconstitution inflammatory syndrome. And then the patient is going to have, because of this reaction, fever, night sweat, fatigue, and new or worsening disease. This condition usually arises within 1 to 12 weeks of starting the CART. Common pathogens associated with IRIS includes tuberculosis, that was unnoticed, right? Cryptococcosis, the avian complex, the pneumonia gyrovecii, cytomegalovirus, hepatitis, and herpes simplex. So, because some symptoms of IRIS are similar to those of drug therapy side effects and other health disorders, IRIS may go undiagnosed and untreated, increasing the risk for death. Wow. When IRIS is recognized, short-term therapy with corticosteroids is often used to address the inflammatory responses. So this is like a circle, right? You don't see an infection, then you took a drug, then the drug causes another side effect, and then you have to take steroids, and then you are at risk for osteoporosis, hyperglycemia, la, la, la. It's a very sad situation for these patients, right? So we are going to stop here. When we come back, we are going to talk about gas exchange facilitation in patients with HIV, and then page management, nutrition, and we are going to talk about some other topics like Kaposi sarcoma, and then managing diarrhea, preserving the skin integrity. It's all about patient education, and let's stop here and then let's focus on all these factors, starting with the gas exchange, right? Facilitation in a few minutes. So let me stop here, and when we come back, we'll be discussing part 3 of HIV.